Hi everyone, my name is Michael Perry, and today I'll be talking to you about bipolar disorder. Bipolar disorder is a cyclical mood disorder characterized by depressive symptoms, which are similar to those of major depressive disorder, and periods of mania or hypomania. Bipolar is a very complex disease with symptoms that are similar to other mental illnesses and disorders, which makes diagnosis difficult. Patients often wait 10 years or more for a correct diagnosis of bipolar disorder. Bipolar is found in about 2% of the world population, and it has a very strong genetic component. Treatment of bipolar typically consists of the management of acute symptoms in conjunction with prophylaxis during healthy periods. In order for a diagnosis of bipolar to be reached, there must be a cycle of depressive and manic symptoms. Depressive symptoms are similar between major depressive disorder and bipolar depression, and they include persistent sad or irritable mood, anhedonia, significant changes in appetite or weight, changes in sleep patterns, psychomotor agitation or retardation, fatigue or loss of energy, feelings of worthlessness, excessive guilt, diminished ability to think or concentrate, and recurrent thoughts of death or suicide. Often, bipolar depression is indistinguishable from major depressive disorder, so the occurrence of mania or hypomania is the distinguishing symptom to achieve an appropriate diagnosis. Mania and hypomania are similar, and they define bipolar 1 disorder and bipolar 2 disorder respectively. Mania typically lasts longer than hypomania, and most diagnostic criteria assert that mania lasts at least 7 days and hypomania lasts at least 4 days. Further, mania often leads to significant impairment of functioning, unlike hypomania, in which the mood is definitely different from normal, but there is no substantial impairment. Mania, unlike hypomania, may also be characterized by the presence of delusions and/or hallucinations or by the need for hospitalization. Typical symptoms of mania include elevated or euphoric mood with a tendency towards irritability, increased energy and activity, a reduced need for sleep, a sense of grandiosity, disinhibition, especially in regard to sexual behavior and finances, which can be life-altering, increased subjective speed of thoughts, or the feeling that thoughts are racing, increased distractibility, and enhanced perceptual experiences. For example, sounds are more harmonious or colors being more rich. Bipolar also has features that may help clinicians identify and treat the disease, though they're not necessary for diagnosis. A patient with bipolar will typically spend 75% of their symptomatic time in depressive states. Bipolar depression can also be distinguished from major depression by things like the rapid onset and offset of symptoms, concurrent manic and depressive features, psychosis during depression for instance, and atypical symptoms like increased appetite or hypersomnia. Bipolar is a disease that is highly impacted by genetics, with the Queensland Institute of Medical Research suggesting that genetics account for as much as 70% of the risk of developing bipolar disorder. Other research shows that while the genetic risk is apparent, genetic risk assessment is still very difficult due to the number of alleles associated with the development of bipolar. Abnormalities in neurotransmitters such as dopamine, serotonin, and norepinephrine have also been linked with bipolar disorder. Other risk factors such as childhood trauma and adversity, illicit substance use, and even IBS have been identified as having correlative relationships, but more research is necessary to concretely identify the nature of these relationships. The Australian Bureau of Statistics says that bipolar disorder affects about 2% of Australians over the age of 16, which is congruent with the worldwide average. Men and women develop the disease at similar rates in Australia, with 1.8% of men and 2.1% of women having bipolar disorder. While the ABS doesn't specify for bipolar specifically, their research suggests that women are more likely to seek professional help for affective disorders overall. Bipolar has drastic effects on the Australian population, as it carries the 10th highest burden of disease for women and the 9th highest burden of disease for men, meaning Australians are losing significant years of their lives due to bipolar disorder. The Royal Australia-New Zealand College of Psychiatrists has identified the best course of treatment for bipolar disorder as the Actions, Choices, Alternatives framework. This framework includes three components. Actions form the foundation of management. These are considered essential and must be put in place where possible. They include lifestyle changes and psychological interventions. Choices involve recommended pharmacotherapies that should be trialed initially, followed by more complex regimens and combinations later on. Alternatives include additional strategies and physical treatments such as electroconvulsive therapy and alternative pharmacotherapies not typically used for bipolar. Non-pharmacological treatments make up the actions portion of the framework. Patients may implement strategies like a healthy diet and good sleep hygiene as prophylaxis. While exercise may mitigate the effects of depression, limiting physical activity can help combat manic symptoms along with structure and routine. In terms of the support network, education for the patient, their family, and their friends regarding bipolar disorder is important. Secure housing and steady employment can help maintain a sense of regularity, and avoiding interpersonal conflict can also lower the risk of relapse. The multidisciplinary team may implement risk assessment and cognitive baselines in order to more effectively and quickly identify symptoms. Psychological interventions such as psychoeducation, cognitive behavioral therapy, family-focused therapy, and interpersonal and social rhythm therapy are all evidence-based and have all been proven to be effective in the treatment of bipolar disorder. Medications make up the choices aspect of the framework, and they are typically thought of as treating the mania and the depression separately. However, the efficacy of some medications luckily extends to both groups of symptoms, but combination therapy is the norm. For manic symptoms, monotherapy is preferred using second-generation antipsychotics, but those may be paired with mood-stabilizing agents in order to obtain good effect. Depression symptoms are typically dealt with using mood-stabilizing agents, though some patients may achieve better results through antipsychotics. It is important to note that antidepressants are generally not found to be effective in the treatment of bipolar depression, and their use by people diagnosed with bipolar disorder should be closely monitored by a psychiatrist. Finally, alternative treatments like ECT have been shown to have good effect for patients with persistent manic and/or depressive symptoms. Across all acute presentations of bipolar disorder, ECT is an important alternative with proven efficacy in mania, bipolar depression, and mixed states. As with ECT for major depression, administration varies by the placement of electrodes and pulse width. Alternative pharmacotherapies vary based on which symptoms are being addressed, but they typically include combinations of lesser used medications. Sometimes these combinations may include up to 3 different categories of drug for difficult cases. The link between trauma and bipolar is under-researched, but there are clear increases in risk related to trauma. Childhood adversity is linked to earlier onset and more rapid cycling of symptoms, which can increase the number of lifetime episodes someone experiences. This in turn leads to a higher risk of suicide. Trauma is also typically linked with substance abuse, which may exacerbate bipolar symptoms. Trauma is also correlated with chronic environmental stressors that contribute to more severe depressions, which can then cause an even higher risk of suicide. While the link between trauma and bipolar seems clear to researchers, they are unable to make any claims at present due to the need for increased research specifically regarding trauma and bipolar disorder. To wrap things up, we've established that bipolar is difficult to both diagnose and treat, and it is more likely to develop based on genetics and trauma. Emphasis should be placed on prophylaxis and adherence to medications to avoid severe symptoms. Australia experiences similar rates of bipolar disorder to the rest of the world, though our social safety nets may play a role in lowering the burden of disease. Treatment of bipolar disorder is best suited to a plan which involves taking action in one's life, making choices about medications, and considering alternatives when symptoms persist. SNUG 206 has shown me that many illnesses present similar symptoms, so the difficulty in diagnosing bipolar isn't unique. These challenges highlight the importance of therapeutic relationships in mental health, more so than in many other fields of nursing.